No, CT scan we are going to upgrade.
अरे वाह, चलो, congratulations, sir.
Yeah. But as of now, we cannot afford MRI.
Nah, sir. Even I cannot afford MRI, sir. MRI is a different thing, sir.
Yeah.
You are no more a radiologist. You are a businessman.
Okay, so we started now. Good morning, friends. Welcome back to Saturday Club of Baroda morning meeting. And today we have once again with us Dr. Shilsa. He has been regular with us since long. Please mute. I request everybody to mute, please. So we have Dr. Shilsa with us. He is a consultant diagnostic and interventional radiologist based in Vadodara. He is MD PDCC in radio diagnosis. His areas of special interest are interventional imaging, MSK imaging, obstetric imaging, and he has contributed to CCRI case series. And his current affiliation is the owner of Advanced Diagnostic Imaging Center in Vadodara. And today he will be talking to us regarding ultrasonography of nerves and muscles. A very unusual topic. We don't hear much about ultrasonography of nerves and muscles. So we look forward to very informative talk from Dr. Sheel. So over to you, Dr. Sheel. Thank you.
Good morning to everyone. First of all, thanks to the Saturday club meeting. Once again, I am back. And what a lovely period it's to present on a very unusual topic, the role of ultrasound in nerves and muscles. Friends, this is something different from what routinely everybody is aware. Musculoskeletal ultrasound, where we do ultrasound of the joints, ultrasound of the tendons and the soft tissue. This is totally different. Most importantly, let me start. Why ultrasound in a neuromuscular disease? These days, it's an emergency, emerging a diagnostic subspecialty. The more importantly, the topic for today is the focus on nerves and the muscles. What we are interested in, whether ultrasound can help to diagnose a neuromuscular diseases, whether it can provide a roadmap to the consultant in identifying whether at all the nerves and the muscles are the attributing factor for the disease, and can we categorize whether nerves are involved or muscles are involved. The muscles which may be involved in the form of involvement of a muscle hypertrophy, atrophy, fibrosis, or a trauma-related changes. It at all, if the nerves are involved, whether the nerves are involved by a tumor, whether they are getting compressed, or whether there's a transaction. Now, traditionally, if we speak of nerves, if we speak of muscles, everybody will be aware, yes, you want a diagnosis, why don't get an MR done? Why don't we get a CT done? Just a few seconds, role of radiology for everything else is different. For CT scan, it provides information about the bones. MR, it provides information for everything else apart from the bones. It isn't it, the MR won't prove an information of the bones, but whenever trauma is considered, CT is a better, easier modality. So why ultrasound? Ultrasound is most important, cost effective, its efficiency, and most important, its ease. There are other things where I would say ultrasound proves as a more important modality as compared to CT and MR. Yes, it cannot replace CT and MR, but few of the points whether it will be important is first, it's non-invasive. If CT is considered, you are radiating the patient. A 10-year-old kid or a patient with recurrent nerve and muscle disorders, they require frequent imaging. So why unnecessarily radiate a patient? MR, it helps in more important because it's a real-time imaging. In MR, it's not a real-time. Most important, it is enhanced diagnostic accuracy. If a clinician is suspecting an involvement of a nerve at a specific level, why we do an MR of the entire limb? For example, a common peroneal nerve in the lower limb or a median nerve in the wrist is suspected, you need to diagnose it at a specific level. We don't need an entire nerve to be evaluated, where ultrasound is more helpful. Obviously, patient comfort. The patient is in a sitting position, is a lying position. You don't need to sedate it. You can talk to the patient, and that importantly, immediately after the procedure has been done, the treatment initiation will be faster, unless like MRI, where a radiologist needs to sit, he needs to evaluate all the sequences and treatment initiation will be delayed. More importantly, it's a dynamic assessment. Any nerve, any muscle you speak, those lesions, they help in contractions, relaxations. The nerves, they usually don't follow a straight course. They are wavy, they are irregular, tortuous, somewhere passing anatomically. So most important is the real time. Now, you will be shocked to listen. Going back to the history, earliest reports of ultrasound evaluation dates back to 1980. Yes, it's 1980 where initial cases of muscular dystrophy were reported. So why so bad and why it's gaining popularity now? Most important is the advent of technology. The nerves, superficial nerves, they are more superficially located. So we have a specific transducers. As on CT scan, everybody must be aware, was a more slice scanner, MR is a more Tesla scanner. Similarly, ultrasound is all related to the probes. Here, there are different types of probes. Ultrasound, it helps in movement of the sound waves. So a frequency which is higher, for example, on the left, it's something written as 18L. So it is a 18 megahertz probe. If it is a 9L, it's a 9 megahertz probe. Now, just a few lines. Hertz is the penetration. So higher the penetration, poor the resolution, but better imaging. So for example, if you're interested in seeing something which is more superficial, you need something called as a higher frequency probe. For example, in this part, we see a probe which is somewhere over placed in the fingers, but you see the frequency, it is something 18 megahertz. So you will be able to see something which is more superficial better. At the same time, if you are seeing something which is related to the abdomen, we'll be using a lower frequency which is 9 megahertz, 3 megahertz. So before we advise an ultrasound, it's very important, does the machine has a proper equipment to do that? Obviously, the expertise of the performing radiologist is the most important, but also it's the equipment. Now, ultrasound depends upon the image. So we have different images appearing on a different way. It is very simple. Anything which is fluid, which is allowing the sound waves to pass through it, won't be reflected back. So we have different colors of white, different colors of black. When an ultrasound, it passes through a specific thing, if it simply allows it to pass through it, then we won't get anything. So it will be totally black, as seen on the image on this side. It's all fluid. What happens is the ultrasound is coming, waves are coming, but the sound waves are not reflected back. So this is all black. At the same time, you see a bone. It comes, it hits the bones and it goes back. So what we are seeing, it's totally white. So those are the two different things. We see fluid, we see bone. Everything in between, the ligaments, the tendons, the nerves, the muscles, they all fall in between. So these are the basic appearances and we need to evaluate on basis of this. Going to the topic, ultrasound in neuromuscular diseases, I have shortlisted into two different parts, the muscle part and the nerve part. Let's first talk of the muscles. So once starts from the brain, we reach the nerves and they end up in the muscle. So we talk of the muscle first, and then from once the muscle part is ruled out, we start moving towards the nerves. Now, the basic normal muscle on ultrasound, it appears as more black or an isoechoic appearance, and there are small muscle stria which will be appearing as a dot light. This is an image on the left and this is an image on the right. More importantly, what we are concerned in between is the brachialis muscles appears different on an axial imaging. It appears different on a cross-sectional imaging. So the image on the left is a cross-section where we keep the probe longitudinal. The another is the probe transverse. So depending upon how the probe is kept, the images will be different. It's very important before we label as a muscle tear, a muscle strain, the images acquired are very important. So unlike MRI, unlike CT scan, we usually don't interpret ultrasound on imaging unless and until the technician is very well trained. Usually what happens in other countries where the availability of radiologists are less, so ultrasound technologist usually does it and a radiologist reviews the imaging. But in our country, usually the radiologist himself does everything, so that what we call this as something called as an anisotropy. Anisotropy is the probe has not been kept properly and so it mimics there is a tear. So it's very important how we keep the image. Now, depending upon this, we can classify the muscle thickness, the appearance of the muscle. This is something called as the pennation angle. You see the one on the left, you see the one on the right. Those are the different muscle thicknesses. There's a superficial part, there's a deep part. As the ultrasound waves pass through it, you are able to uniformly see the muscle thickness, and something they called as a pennation angle is the appearance of the uniformity. So anything depending upon the muscle thickness, whether it will be in the superficial part, mid part, or the deep part, depending whether it's a fat, is a fascia, these ultrasound waves, as it gets reflected, that will be distorted. So once they are distorted, you won't be seen in as good as images as compared to the other part. And that's how we see a muscle inflammation on ultrasound. It's something similar to what we see as a fatty liver. It is a very common concept where we see liver on ultrasound, and depending upon how much fat is inflamed, we see the liver. Similarly, we see the muscle. This is a simple scaling of a vastus lateralis muscle, which helps in storing of inflammation. It's very simple. As on ultrasound, we see liver, we see the portal vein wall. On ultrasound for the muscles, we see the adjacent bones. On the first floor, we see the muscle, that's the bone, but we can see individual muscles, we can see the stria. Now, in a floor 2, you see the muscles, but you won't be interpreting the 5 as good as that. But still, the bone is preserved. On a grade 3, the entire muscle is totally lost, but still you are able to see the bone, so the penetration has not totally lost. But if there's a severely inflamed muscle, you won't be seeing anything beneath it. This scoring helps us to grade an injury, grade an involvement and inflammation, and most important, follow-up. Any patient with a diabetic involvement or a patient with a trauma involvement or inflammation, neuropathy, where the muscles are getting fibrosed. So this is very helpful in staging the muscle involvement. Now, most important is what are we trying to evaluate when we see at a muscle? First, whether the normal muscle architecture, is it preserved or is it lost? Second, muscle morphology. Though the architecture may be normal, but overall muscle thickness, whether it's dead. Most important, the dynamism, where we can ask the patient to contract a specific muscle and evaluate directly whether that muscle is contracting or not. So most important, it should not be just as a screening tool, but it helps us clue and direct us to what will be the next differential to scan the patient and let us know whether the disorder lies at the level of muscle or more higher. Now, most important is in this particular window, you will be seeing the role of ultrasound. The best part is movement. In this particular video, you will be able to see nothing. But as good as you see the video, you see something which is moving, and that's the best part. So the real fun of ultrasound is dynamism. You see something, you are helpful in it, and once it moves, that's the best part. So you are able to really see the movements of the muscle fibers, which is the real fun of ultrasound. Most important is, in doing this, you will be able to see the whole muscle contractions, you will be able to see simple fibrillations, and you will be able to see the fasciculations. And once all this has been done, it's most important, even guides us if a specific muscle biopsy has to be taken, which muscle is involved the most. For example, with a lower limb involvement, ultrasound can guide whether it's the adductors are more involved or the abductors are involved, whether it's vastus lateralis more involved or whether it's a quadriceps which are more involved. And that is a real advantage of ultrasound. So considering the different parts, the muscle, it helps in the three different forms. The muscle on the left is a normal image, a neurogenic involvement where the nerves are involved. It's not primarily the muscle, but a muscle involvement where the disease lies in the muscles. So this is how ultrasound can say and guide the consultant the disease lies more proximally in the muscle, or more proximally in the nerves rather than distally in the muscles. So we see whenever there's a fatty involvement, the total muscle will be increased in bulk. That's the normal image on the left. This is the skin. That's the subcutaneous fat. That's the muscle, and that's the bone. Now, what's happening over here? If there's a spinal muscular atrophy, the nerves are involved. You see the muscle thickness will be less. So we are very sure the muscles are atrophied. But if the primarily involvement is myogenic, the muscles will be more homogeneous, they will be increased, and there will be preserved muscle to subcutaneous ratio. As compared to now, neurogenic, whether there will be atrophy, the subcutaneous fat will be preserved, the muscle will be atrophied. So we say that the muscles are now not getting proper stimulation since long. So it's a more of a neurogenic etiology rather than a myogenic etiology. Now, this is a perfect example. A patient suspected with a sciatic nerve involvement. She had a fall, and then patient complained of a sciatic nerve involvement, and MR was done. MR was normal. Patient was sent for a sciatic nerve ultrasound. But what we found out was the specific muscles. That's a gluteus major. You see the fibers and you see something over here. The muscle fibers post-traumatic, they were involved. So that was the main culprit of pain rather than the nerve. As compared to the left side and the right side. On the right side, as I said, these are the uniform parallel muscle fibers, which are most importantly normal. Whether on the left side, you see totally disorientation. Those are the muscle fibers which are involved. So this is a type of a strain which is involving the gluteus muscle. Obviously, the orthopedician will be trying to classify this as a strain, as a partial tear, as a complete tear. But more importantly, in this particular region, it was involvement of the muscle rather than the involvement of the nerve, which was the culprit. Now, nerve diseases. So, once any patient with a specific etiology, specific complaint presents, we have ruled out the nerve diseases, muscle diseases. Now we try to focus on the nerve part. Basically, what are the nerves? The nerves which we are talking more of they are a peripheral nerves. We are not at all interested in evaluating the major nerves, which are the cranial nerves, which are the nerves within the body. But what we taught is the peripheral nervous system as it starts exiting from the spinal cord. A nerve, again, this is a small part of the probe. What we are evaluating is the median nerve in the hand, and most important, it shows small black dot-like structures, which are the fascicles, as depending on the placement of the probe. If we put the probe longitudinally, we see small black dots which are cutting through the images. if we place the probe parallel to it, we will be seeing them as a normal longitudinal images. So most important, how we place the probe is very important for evaluation. Now, most important, I will try to differentiate the entire thought into 5-6 points: the technique, the normal anatomy of the nerves, any injuries, tumors, traumas, and subluxations. Now, most important, going back, the nerves has 4 different parts which the radiologist should be aware before performing it. The nerve, individually, any nerve, maybe a median nerve or a peroneal nerve or a sciatic nerve, it has an outermost part which is something called as a perineurium. Those are the individual fascicles. Within this, we have an individual nerves surrounded by a small lining called as a perineurium, multiple fascicles. Obviously, there are vessels within the nerves, and the outermost part is something called as an epineurium. Now, why it's very important to know? Because certain diseases may be involved in a certain way. Now, most important, probe placement is very important. The probe is very important. So for a routine abdomen ultrasound, what the probe we used, we cannot use that probe to see a median nerve. So availability of the probe is very important. Now, how a median nerve or a nerve, normal nerve looks on an ultrasound. As we put the probe, we see small black dots-like structures. Those are the nerve fascicles. Similarly, I would like to share a small video. You can see this patient had presented for a brachial plexus ultrasound. Nowadays, lot of anesthetists are doing it. This is one of the talk from my friend Dr. Amit, who had presented this talk in one of my talks where brachial plexus ultrasound we were sharing. You can see it's so easy. You put the probe, as good as you put the probe, we can see how it slides through it, and immediately we see the. So that's the best part of there's something called as a real time. We put the probe, as we do the placement, we can see the nerves, we can simply gently move the probe upwards, we can move the probe downwards, and that's how the best part is this. So this is the most important thing of anisotropy. How we place the probe is most important for imaging. Now, an involved nerve may have an abnormality related to the nerve, something called as an intrinsic abnormalities, an edema or a lesion, which may be a neuroma, maybe a schwannoma, neurofibroma, or it may be an extrinsic nerve abnormalities that may be related to some compression, a tenosynovitis, or a fibrosis. Compression may be an extrinsic structures, involvement of the muscle, which is compressing the nerves, a tenosynovitis, where we have an inflammation of the nerve sheath, or most important, we have some fibrosis, some scarring in the perineurium, which is causing the nerve abnormalities. So depending upon that, we'd like to do it. Now, most important is nerve injury. The nerve injury is very important nowadays. Any patient who presents with trauma, everybody is concerned about the bones, the muscles. But nowadays, with the advent that plastic surgeons, they are treating nerve injury more cautiously. We had lot of patients who had presented with fractures, spiral groove fractures where the radial nerve is very important, a tibial condyle fracture where the common peroneal nerve is very important, a patient with a brachial plexus injury, a patient with an injury in the axilla. It's very important to identify the nerves. Now, depending on the availability of radiologist, if the specific radiologist is not available during surgery, the plastic surgeon will be called up. He will be identifying the nerves and simply put a clamp. Then the patient will be treated for vascular injury, will be treated for muscle, will be treated for bones. And once that's done, later on, once everything goes normal, function part starts. The patient has a normal appearance, but then doesn't function. At that time, identification of the nerves before surgery will be very helpful. So most important, when we see a nerve injury, what the neurophysician, orthopedicians are concerned is something called as a neuropraxia, axontomesis or neurontomesis. It's very simple. A normal nerve is something like an electric wire where it will simply allow us to conduction. Sometimes what we do to evaluate a nerve is something called as a nerve conduction study. What we do in nerve conduction studies, we stimulate the specific group of muscles. Depending whether the conduction is allowed to it, it's something called as a normal. If there's a conduction block which is reversible, they usually label the term as a neuropraxia. If the axons are divided, it's something called as axontomesis. But you see a total nerve damage, it's something called as a neurontomesis. These words are very important in grading the injury and very important in prognosticate whether this patient in future will come down or not. So when we see ultrasound for a brachial plexus, they are interested, there's a preganglionic tear, that is avulsion. The nerves are totally separated. Sometimes the nerves are not separated, but after coming out, they will be totally damaged, something called as a neurontomesis, where the neurons are damaged. You see an axontomesis where individual nerves are normal, but there's a traction injury. That's how it's important. Now, this is an example, a patient with a radial nerve involvement. What we see over here is, this is the part of the humerus. Something in between we see is the fracture of the humerus. And this patient at sent was post fracture of a spiral groove, supracondylar region, now was not improving. He had a persistent wrist drop. The nerve conduction showed there was a block in the region of the spiral groove. So what's happening there? Whether the nerve is involved, definitely. But whether the nerve is a transaction of the nerve, whether there's a fibrosis of the nerve, or whether the nerve is getting entrapped in between the fibrosis or the fracture or the implant plate. The real answer is ultrasound. We can see the nerve on the left side, we can see it entering the spiral groove. As it crosses the entire spiral groove, it is getting enlarged. You see the nerve over here, it's very small, that's normal. As it enlarges, it's getting increased in size. Then that's the part of the fracture and then it exits. So most important, happier for the orthopedician, the nerve is intact. Obviously, during surgery, when he was operating, he had identified that the nerve was normal, but this is something more helpful for him to say the nerve is really normal. Second, whether the nerve is normal, but it's getting thickened. So what's happening? It's the nerve properly thickened, whether it's getting entrapped. So this specific was edema of the nerve, which is usually neuropraxia. Due to trauma, there was stretching of the nerve. Sometimes we see specific enlargement, no trauma, then also the nerves will be enlarged. These are the images of the brachial plexus. We see the lateral cords, we see the musculocutaneous nerve. You see the entire nerve is enlarged, thickened, wavy. These are the typical appearances of neuropraxia, where the nerves will be involved, but they will be thickened along the course. But individual fascicles will be normal. Sometimes what we see is axontomesis, where you see the nerve is grossly enlarged, but in between, we usually don't see the small individual fascicles. Here, initially they were using the term neuroma in continuity. What they meant was neuroma is the individual fascicles are lost. So now we are unable to identify where are the fascicles. What we are seeing is a bunch of organized fascicles clumped up together within the nerve and passing along its course. It's very important that this patient has an axontomesis and the involvement at this particular level and should be planned effectively. Now, adjacent tissues which are very important in two important parts is intact epineurium and the supporting scaffold. Now, this specific changes, another thing is neurontomesis. This patient of a brachial plexus injury, specifically musculocutaneous nerve, involvement of the part of the right arm, what we see is the part, there's a normal anatomical image. We see a lateral cord that continues as the median nerve, and we see something in the pink is a part of the nerve which is arising and crossing towards it. That's the normal anatomy of the musculocutaneous nerve. Very easy. We just keep the probe at specific place, and what we see is a complete transaction and injury of the musculocutaneous nerve. And at the same time, we can highlight and mark on the skin. That's the proximal end, that's the distal end, distance between two. So first, it helps in diagnosing. Second, it exactly states the site of injury. And most important, if at all they're planning to do some nerve drafting, the specific nerve before surgery will help the plastic surgeon or the orthopedician to say how much nerve will be needed, what will be the length will be needed, and that's the planning of the surgery. Another example where we'll see is the inflammation of the nerve. What happens in this is the nerves are uniformly involved, but they are bulky. Most common we see in the region of the ulnar nerves, we see in the median nerves, we see at the site of trauma of the bones. The nerves are increased. Very classically, you see the nerves, but individual fascicles are totally preserved. At the same time, those are the nerves where we are able to see the fascicles, they suddenly increase, they suddenly go normal. Those are the classical findings where we see neuritis. This was a patient who had a clinical syndrome of cubital syndrome. The ulnar nerve at the level of the elbow was getting compressed at the medial condyle. Operated, usually they do an anterior transposition. That was also done, but somehow the symptoms were not improving. So ultrasound helps to say the transposition has been done perfectly, but the nerve is still edema, and that's why the tingling is not growing. Nothing else has to be done right now. Another thing is most important is tumors. Ultrasound helps us to identify the nerves which are involved, the tumors which are there, why we can say the lesion enlargement. Most important, the nerve entering the tumor, the nerve exiting the tumor. That's the best part. This was a case where a C5 or a C6 nerve root before they formed the superior division was involved. This was a young chap, 20-25 years, presented with a left supraclavicular region swelling. Ultrasound or an imaging done elsewhere suggestive of a node, and please biopsy it. Before doing the biopsy, what we were able to find, it was not a node, but it was a nerve lesion. We can see the nerve entering it, we can see the nerve exiting it, and the involvement of the nerve. Very important, this was a nerve tumor per se, and it was not a lymph node. So before biopsying it, we need to identify what we are biopsying it. Now, another patient, tingling in the left neck and nose deficit. The image I am showing is how easy it is to do an ultrasound. You just need to put the probe in the gluteal space. The patient is in a specific position, and we just need to start screening. Now, this is the image where you can see the ultrasound, you can see the sciatic nerve crossing it. That's how it's easy to perform an ultrasound. What we are able to see was large involvement of the muscles of the nerves as it was coursing through it. We were able to identify the nerves as enlarged nerves, and on ultrasound there was a large elongated lesion which was involved in the nerve per se. What we saw, this is a schematic representation. On the left is the lumbosacral plexus, on the right is the sciatic nerve. So there was a diffuse involvement of the nerve. As we drawn further, we identified and we saw that was a representative MR of the same patient. And what we were able to identify on MR was this patient did have an MR imaging where involvement of the nerve was there. We see a lesion. The biopsy was performed from the lesion, and this turned out to be a gangliomyomatosis of the sciatic nerve. It was very rare. Very few cases have been reported. So what we saw as a presentation of the sciatic nerve was basically an involvement of the entire lumbosacral plexus going down to the sciatic nerve. Very commonly, we see the nerves in the region of the supraclavicular plexus. We see the nerve roots arising from the part of the brachial plexus, and the nerve roots are entering the lesion. So this is a large lesion in the supraclavicular, probably a complete normal loss of divisions and the entire lesion which is involved in the nerve roots. This patient turned out to be a spindle cell neoplasm, which was involved in the part of the divisions of the brachial plexus in the supraclavicular. So before biopsying it, we should be aware what we are doing it, because we see a lesion, we see the nerve roots entering the lesion, we see the nerve roots exiting the lesion, and before doing it, the ultrasound is very helpful in providing the rough idea what we're doing is not a mass, it's not a node, but probably involvement of the nerves. Most important, very frequently, the commonest indication for nerve ultrasound will be nerve entrapment, impingement, something we see very frequently. Now, why it's happening so commonly? The main reason is the nerves, they don't routinely follow a routine course. For example, in a carpal tunnel, the median nerve is getting compressed at the wrist. In a cubital tunnel, the ulnar nerve is getting compressed at the elbow. In the Bryan's canal, ulnar nerve is getting compressed at the wrist. Similarly, we have an anterior interosseous nerve entrapment, a posterior interosseous nerve entrapment, a tarsal tunnel syndrome. But why all this? The main reason is the nerves, they routinely don't follow a straight course and that is available. Now, most common scenario, a tingling in the hand with paresthesia. So patient comes to us after seen by a super specialist, and they try to evaluate and they try to find out this patient has a bilateral carpal tunnel syndrome. So usually before the advent of ultrasound, a nerve conduction has to be done. Nerve conduction shows the involvement of the nerves, and then we try to find out what's the real problem and release has to be done. But now every orthopedician, every neurophysician, before asking the consultant, a surgeon, to release the nerve, though nerve conduction study has been done, they will send for an ultrasound. The main reason is ultrasound, despite showing the findings, it will help in ruling out many things. I will show in this particular case. I showed earlier the nerve will be involved. So when we suspect a carpal tunnel, it will be involved nerve or it will be an extrinsic nerve abnormalities. It's very important. If we identify the extrinsic nerve abnormalities, then unnecessary surgery won't happen. This is a routine anatomy of the carpal tunnel. So what it is, there's a tendon sheath. Above it is something called as a carpal tunnel. It's a flexor retinaculum. Beneath it, the nerve passes. So when we see a carpal tunnel syndrome, the nerve is getting compressed. But there are many factors which can lead to this compression. Most common, it is this retinaculum compressing the nerve. But mind well, there are conditions where the tendons will be inflamed and compressing the nerves. There will be some lesions compressing the nerves. Usually what they do in release is they simply release the part of the retinaculum and relieve the symptoms. But prior to surgery, if this is not the culprit, the symptoms won't leave and the patients will suffer. That's how ultrasound tells us why. Is there an involvement of the nerve? Yes. Second, where exactly is the nerve involved? Is it at the carpal tunnel? Is it more distally? And second, next what? This is the most important part to identify whether it's a retinaculum thickening or whether it's a tenosynovitis. This is a classical example where we see a nerve which helps coursing through it, and there's a edematous median nerve and the changes of retinaculum which is causing this. So now the patient the orthopedician should be told to release it, and then only the symptoms might improve. More importantly, sometimes it is the compression of the flexor tendon sheath and not the retinaculum. In the picture above, you see the flexor retinaculum which is causing the compression and edema. Sometimes there is no flexor retinaculum thickening, but it's the tenosynovitis which is causing it, and that may be the reason. So ultrasound will be very helpful in identifying this. You see over here, there's the entire nerve. The part of the subcutaneous plane is normal, but beneath it, there are the tendons. These tendons are compressing it and relieving to the symptoms. Simple. That's how an ultrasound of the median nerve at carpal tunnel has been done. We see the nerve. The black thin over here is the nerve. Those are the entire flexor tendons. That's the normal vessel over here. And as we see, the nerve is getting compressed because something is pushing it from beneath rather than something is compressing from above. So this patient, if you release the flexor retinaculum, the symptoms won't grow. And that's why before operating, the clinician is interested in knowing, will the release help the patient or not? That's how we report it. So most common cause first is the carpal tunnel is the flexor retinaculum thickening we release. Very importantly, though rarely, is an inflammatory conditions of a tenosynovitis that is causing the nerve compression. In such patients, immediate surgery won't be helpful. Patient needs a workup and then requires a surgery, and the surgery at all not a flexor retinaculum release but a flexor tendon sheath surgery. Cubital tunnel, again, it's another thing which is very common, where we see the nerve which is getting involved at the level of the elbow. You see the nerve crossing it, the nerve is enlarged, edematous. As it passes through it, we can see the involvement. What's happening is sometimes this is the picture representation of the ulnar nerve. It passes through it, but there is evidence of fibrosis. There is evidence of scarring due to trauma, and that is causing the involvement. So in the earlier case, we saw a uniform enlargement. Apart from that, nothing else was there. Here also we see an enlargement, but adjacent to the nerves, there is lot of fibrosis, scarring, secondary to the fracture, which is the culprit. Most important, another thing we see is the peroneal nerve involvement, where we happen. This is a very interesting case. The patient had presented immediately after a laparoscopic surgery. Laparoscopy was done for some ACL or a PCL tear. It was repaired. As soon as the patient came out, suddenly the patient had a foot drop. Ultrasound was done. What we saw, this is, as we were saying to pass through, is this is the normal nerve. As it was passing through it, the nerve was getting compressed at two specific levels. This is a schematic diagram. That's the common peroneal. See at it now. It goes, it turns over here, and that's the common peroneal nerve. That's the posterior part. And at this particular site, a stitch was taken after the laparoscopic repair. So what we see on ultrasound is, you can see the one thing above is something that is causing compression of the nerve over here. See, you see something there. So this is the nerve which is getting compressed at this particular site. After this was reported, immediately the orthopedician was told at the level of the suture or the skin mark, there is something which is causing impingement on the nerve. And immediately the patient was taken for surgery. At night, he was explored and they found out that basically it was the nerve which was encircled by the suture at this particular site, which was the culprit for the foot drop. So within hours, they immediately relieved it and the patient was normal. Sometimes in the case of fractures, we see the involvement. Those patients with the complex tibial fibular fractures, we see the involvement of this. Now, more importantly, what we can say, there are fibular fractures, but the nerves are spared and they are not at all involved. Sometimes even ultrasound can say the muscles are heterogeneous. So it's the tibialis anterior muscle and not the nerve. So it's something called as a compartment syndrome. So again, patient will just present as a foot drop. but ultrasound will say whether it's the nerve, it's the muscle, or it's the entire tissue which is involved. So once we label that this patient does has it, follow-up has been done, and these patients usually they improve and all. Now, very few times we get a patient with a specific foot drop. The patient complains to us, patient is able to move the limb, but that's not able to move the other limb. So this is the classical case of a foot drop which was under evaluation. Now, what we saw was there was a large Batrus cyst which was causing compression over the peroneal nerve, and because of that, the patient had a foot drop. So this is the nerve at the above. There's a large cystic lesion. It was classical of a Batrus cyst, and because of this Batrus cyst, the nerve was getting compressed. It was getting displaced. So the problem lies in the foot drop at the level of the toes, but because the nerves are crossing at a specific level, it needs an evaluation of that particular part. Sometimes what we see is entrapment that occurs by fibrosis. We see the nerves, we see the thickening of the nerves. And most important, there will be sometimes edematous of the nerves at a specific type which is getting compressed. So that's how we report. We see the nerves, we see the enlargement, we see the comparison. Most important, we can see the right and the left side simultaneously, and we can also help in rotating the nerves which are involved. These are the cases where the patient had a complex fracture of the spiral groove. The nerve, as it passes the spiral groove, it was totally transected, and we can see the entrapment levels. Most important, as I said earlier, if we see the radial nerve is involved, we can even site mark, and we can say those are the proximal ends, those are the distal ends, and that will be helping the patient to guide what's next. Then this gentleman had a swelling of the left eyelid. Some tumor was suspected. Ultrasound was done. So it's so easy to just put the probe over it and we see it. So what happening? There is nothing related to the eyeball, nothing related to the eyelids, but it is something related to the skin and the subcutaneous plane. So this patient had a large, giant neurofibromatosis. This you see something that's the skin and the subcutaneous plane. We see a lesion which is involved in the skin, subcutaneous plane, and now that's involved in the eyelid. So this was a case of a plexiform neurofibromatosis involving the part of the eyelid as an eyelid swelling. So the consultant should be told it's involvement of the skin and the subcutaneous plane, but not the orbit per se. Sometimes we see an intraneural ganglions. There's a common peroneal nerve traversing it. We see the nerve sheath and we see the lesions within the nerves. So here, this patient had a chronic symptoms. That's the nerve which is passing through it, and we see those are the lesions. So this was an intraneural ganglion cyst. Post-operative, they could explore it. They could find the similar involvement, and it turned out to be the ganglion. So it helps in diagnosing. Second, it helps in locating where the nerves are involved. And third, raising the probable differential diagnosis, what may be the rough part of the nerve. So to conclude, the neuromuscular ultrasound is totally different from what we do as a musculoskeletal ultrasound. I am not talking about the joints, the tendons, the nerve, the sheath, the fluid, but we're talking specifically about the nerves. Remember, it's most important is the availability of the specific hardware, which is the probe, and important is it's non-invasive, it's cheap, you don't need a sedation, you don't need a radiation. And to highlight, it is not a replacement for a EMG or a nerve conduction study. It's very important before a specific ultrasound is advised. A clinical examination is important to identify what information we need from the imaging. If it's an ultrasound, most important, it will demonstrate the structure. The function usually won't be labeled on this. For that, EMG and NCV has to be done. Once an EMG and NCV shows some findings to categorize, whether the nerves are involved or the muscles are involved. It's the role of ultrasound. So it helps in providing the bridge between the function and the structure, and to highlight whether the pathology lies at the level of the nerve or at the level of the muscle. Last but not least, there is something future about ultrasound where specific nerve conduction study, specific electromyograms, they can be done with the help of ultrasound. That's the main part. And obviously nowadays, lot of neurophysicians use an intra-operative ultrasound. They want to see a specific lobe. During the surgery, they use a particular probe and they highlight it. Those are the recent advances of ultrasound. So most important, when we get an investigation of a nerve, history is the most important. Second thing is the physical examination, what the information is provided. Obviously, ultrasound is not a bypass of nerve conduction study or a EMG. It is it's a screening tool to guide what next. That's all, friends.
Thank you, Dr. Sheel. You can stop the screen share now.
Yes, sir.
Yes. So wonderful. Very, very well explained. I mean, so many minutest things you tried to explain as to how this. I think USG is very old, but these are the things which are little newer to most of us as old timers. Many of my senior colleagues would agree with this. And I wonder whether all clinicians are really aware about this kind of modality which is available through ultrasound. So I would like to know more from you whether you are being utilized well or underutilized because of lack of awareness.
So we do probably routine 7 to 8 neuromuscular ultrasounds a day. Many times we get a patient who has been taken for a surgery and patient has been sent for a nerve evaluation because the orthopedician needs to be informed whether a plastic surgeon has to be tapped during the surgery or not. We get lot of patients during emergency after such for that die with a post laparoscopic foot drop. Ultrasound has to be done in an emergency basis. Sometimes when the patient has already been operated, suddenly patient presents with a tingling. So we need to identify whether the implant is impinging the nerve. So it's very well utilized because what happens nowadays is end result is very important. As I told orthopedicians, if they do a carpal tunnel release, they are very sure it will be a 100% job. If not, patient will be explained, I will do a release, but probably 3 months later, the symptoms might come back.
Okay. And you talked about specific hardware. Does it mean only the probe part or the whole machines?
No, sir, it's only the probe part.
So it's only probe.
It's something, for example, we do a routine abdomen ultrasound. That machine should have a cardiac probe. Then only echocardiography will be possible.
Okay.
Similarly, there are specific probes. With this probe only we can see the nerves. So for a routine abdomen probe, even if I don't have a probe, though I may have a knowledge, but then I cannot do it. So those specific probes are the most important. Something like a machine, on a routine CT scan, you cannot do a cardiac CT. Similarly, with this ultrasound machine, every ultrasound machine won't be able to have that probe.
And in the same way, I mean, every sonologist may not be able to do this. You require special training, I understand.
Yeah. Yes, sir.
Okay. So you done some fellowship, or I mean,
Yes,
where
sir.
did you get this training?
Sir, actually, I did this long back from Nizams in 2010. And then since on, we'll be doing lot of things. And now what's happening is on days, the recent awareness about the approach is changing the clinicians to know. So orthopedicians will call up, they will discuss with the peers and say, okay, now an MR is normal. The next thing is I'm suspecting at this particular level, it's the sciatic nerve where it will be helpful, something called as a piriformis syndrome, where the sciatic nerve is getting compressed at the piriformis muscle. So they only talk to us, they discuss the case and they will ask, okay, now MR is normal, the study, this is not happening. At this particular I want to see the nerve. Can you help me? So more importantly, it's very case-based oriented and it's really
It's very good. Otherwise, no radiologist report would always say that correlate clinically. So we used to usually laugh at that sentence. But it seems that now there is true collaboration. I mean, you discuss the case and you threadbare analyze with different modalities. That's great. So now the house is open for other questions and comments.
This is very subjective thing. I think you have to give lots of time. Ultrasonologist himself.
Yes. Very true. Because
Yes.
the man behind machine is very important, I think. And on a personal note, Sheel, we have been very happy to have his services, especially in sonography of kidney, ureter, and bladder, where we try to find out smallest things with his help. So I think it's very important that the man behind machine is well trained and gives enough time, as you said.
Yeah, it's time consuming.
Sheel has disconnected, it seems. Anyway, any other comments?
Sir Sridhar here, I would like to make one.
Sridhar, yeah, please.
Yeah, so I'd like to talk on 2 points. One is in the pediatric realm and one is in the pediatric neurology realm.
Right.
Basically, when I was in pediatrics in Lady Hardinge Medical College, Delhi, we had one thesis where we did ultrasound of vastus, intermedius, and rectus femoris muscle. Okay, so it's basically what happens in children with nephrotic syndrome, their weight and height are good, but we don't know that how much sarcopenia is there. So in PICU, our HOD gave us a topic that to do muscle ultrasound in healthy controls versus nephrotic syndrome patients. And then we in them we found out that although the child appears bulky from outside, but the muscle involvement was showing more sarcopenia as compared to healthy controls.
Right.
So one of the thing in pediatric is the residents should now know, because every ICU has a point of care ultrasound machine. So sarcopenia in a patient in ICU is a poor prognosis for increased hospital stay and increased mortality rate. So that is where a pediatric resident should know where to put the probe, how to analyze the muscle for sarcopenia. So now, because of these studies which are happening, we have all the normal routine controls are available. What is the normal muscle thickness at which level? So this is one of the things which I learned during my pediatric residency to evaluate sarcopenia by point of care ultrasound in PICU. Second, in pediatric neurology nowadays, in any nerve conduction study in EMG room, you have a ultrasound also together.
Yeah.
Basically. So when you do a nerve conduction study, you only stimulate the nerves on the surface. But when you want to check where to put the needle in the muscle for doing electromyography, again we put the probe and check where the muscle is showing some finding. If we are able to see fasciculation and fibrillation with the ultrasound itself, we need not put a needle and give pain to the patient, because doing EMG requires putting a needle inside the muscle. So that's very painful and sometimes patients won't cooperate. So that's where ultrasound helps. Another thing is, suppose if you get a foot drop or a wrist drop in adult, you think that it's a nerve problem. But if it's a foot drop or a wrist drop in pediatric patients, is usually non-traumatic and they are usually because of plexopathies. So they may present with a foot drop or wrist drop, but you should not order ultrasound of that specific nerve. You should order ultrasound of a brachial plexus or lumbosacral brachial plexus. Lumbosacral plexus is very difficult to screen by ultrasound. But we had a case of wrist drop, which was which initially went to hand surgeons and pediatric orthopedics, and they sent to pediatric neurology saying that we want clearance for nerve biopsy because ultrasound showed some nerve swelling of the nerve, radial nerve. But when we retook the history, the child told that she also has some sensory symptoms in medial aspect of the forearm. So we thought that okay, it's not one nerve, it's two or more nerves which are involved. And we did a brachial plexus ultrasound, and it showed enlargement of the brachial plexus. So it is something which you call as idiopathic hypertrophic brachial plexopathy or idiopathic hypertrophic brachial plexitis, and it's an immune-mediated condition. So now biopsy won't help over here. We'll have to give steroids for the patient. So this is few things which I went through in my training, where we have used the neuromuscular ultrasound as pediatrician as well as pediatric neurologist. So these are the few things I wanted to highlight.
Thank you, Sridhar, for those inputs. And I think we end the session here. It's already 3 minutes past 9. So thank you all for joining. And we meet next Saturday morning again. Thank you. Thank you.